Okay, we will go ahead and start our next chapter, which is personality disorders. Let's see if I can move this somewhere that's helpful. Hope everybody is doing well. Just check one more time. Okay, so let's start on personality disorders. And there's some of these that we're probably going to gloss over because there's so many, but you should be able to get a general sense of personality disorders from this lecture because there are 1, 2, 3, 4, 6, 7, 8, 9, 10. There are 12. So again, some of these we're going to gloss over, but you should have a general idea of each cluster by the time we have completed this. All right, so the general outline for this, we'll talk about the general definition of personality disorders, then we'll go into each cluster. There are 3 different clusters, and this is going to include odd or eccentric personality disorders, dramatic and emotional personality disorders, and anxious and fearful personality disorders. So those are basically the ones that we're going to cover today. All right, so first we have to talk about personality, which we talked about for a week in Intro to Psychology. And if you remember, personality basically encompasses the staple traits that make you a unique individual. It's all the things that uh, kind of guide the way you think, the way you behave, the way you feel, again, that make you unique from other humans. And over time, people are going to interact with others in a reasonably predictable way based upon their personality. So if somebody is more extroverted, they are probably going to seek out social events because their personality is one and such that they get energy from interacting with others. Whereas somebody that may be very low in agreeableness, they are difficult to work with on a team. They are hard to make friends with. They are a bit abrasive. And again, you're going to see these characteristics play out for the most part pretty stably across situations, even though once in a while we may put a mask on that may allow us to behave in a way that does not uh, align with our actual personality traits. And personality here it says can change with experience, maturity, and external demands in a way that promotes adaptation to the environment. It can, but in general, we will always return to a baseline of our general personality characteristics. So, for example, even though I'm a very introverted and shy person, when I go to work, I appear to be extremely extroverted. I seek out interaction with others, and I don't appear to be shy. But that is not who I am. And by the end of the day, I'm exhausted and I retreat to an introverted space to recharge my battery. And yes, your personality is going to be affected and is developed, or it develops as the result of genetic and psychosocial factors. So some of the traits of your personality that you have are passed down from your parents. And then, of course, your interaction with the environment is going to, manifest some of those traits. All right, so we have personality traits, and this is what we've been talking about right now. Traits are aspects of personality. Again, they're going to be stable across time and situations. The 5-factor model is the perspective that all of our personalities are organized along 5 broad personality traits or factors. That is basically the accepted theory right now of personality. And these big 5 personality traits include negative emotionality versus emotional stability. That's going to be neuroticism. Individuals who are higher in neuroticism are going to be less emotionally stable. Extroversion versus introversion. It doesn't have to do with whether you are shy or outgoing. It has to do with, those are 2 different concepts. It has to do with what charges your battery. Does being around people charge your battery? If so, that's going to be extroversion. If you are exhausted by people, but you can be around them all day, but at the end of the day, you want to go home and recharge, you might be more introverted. Openness versus closedness to experience. So, are you open to trying new things, trying a variety of things? Agreeableness versus antagonism. Again, are you a great team member or not? And again, we can see these things outside of normal spectrums as well, and that's kind of where the disorders come into play. And there's conscientiousness versus undependability. An individual who is high in conscientiousness, yes, they are dependable, they are reliable, they are on time, they're probably early for things, they are organized. Individuals who are not, they are commonly late, they are disorganized. Their life might look a little chaotic. So those are the big five that we work with in general within trait theory. And so that those are going to be your basic quote unquote normal personality traits. Now, the thing is when these traits are outside of the spectrum of normalcy, that's when we get into trouble and we can see the development of personality disorders. And again, you have to have those three Ds. Again, this personality has to be deviant, so it's outside of a norm. It has to cause distress for oneself or others. So again, somebody's maybe getting in trouble, somebody's experienced a lot of emotional pain, and then dysfunction, in that it's getting in the way of the way somebody lives. Okay, so that's when a quote unquote normal personality exits the realm of normalcy and enters a pathological state, according to the DSM. But again, when we talk about personality disorder, there may be symptoms attached to it, but in general, when somebody has a personality disorder, this is who they are. Just like you and I have a personality that is, again, stable across certain situations, it really doesn't change. That's the same thing with them. It's not like somebody who has depression and has these additional symptoms that are tied to that. This is literally who they are. That is what makes these disorders so hard to treat, as we're going to see here. And even sometimes hard to not just identify, but get people help. Because again, this is who an individual is. Just like you or I, we are who we are. And again, if someone were to tell us, like, oh, who you are is not quote unquote normal, it's outside the spectrum of normalcy, it is pathological, that's going to be kind of hard to believe because this is who I am. It's not as if I'm experiencing outside symptoms. This is truly who I am as a person. Okay, hopefully I'm kind of getting that across. But okay, disorders. So, a personality disorder, it's an enduring pattern of inner experience and behavior that markedly deviates from the expectations of one's culture or society, and is pervasive and inflexible. Again, like a personality in general, and has an onset in adolescence or early adulthood, is stable over time, and causes distress or impairment. So again, just like everybody's personality starts to develop about that time, um, same thing here. It is another personality that is developing. Unfortunately, it does result in pathological outcomes. And yes, a personality disorder, it's an extreme set of characteristics or traits, personality traits that goes beyond the range that is considered to be normal in a society. So it is, yes, evident by early adulthood, because again, that's when you see people's personalities really come to fruition. It's stable over time, like anybody else's personality. It's not going to deviate or go into remission like other disorders may. It's going to be stable. And again, it's going to be evident across multiple settings and environments, like other people's personalities. They are going to exhibit the same behaviors across situations. And it's not really flexible. And so the pattern has to be chronic, and it's not only occurring after like a mood episode or when there's another disorder symptoms that are active, it has to be occurring at all times. That's where we can look at, okay, this is not a symptom of something, this is a personality characteristic. And it leads to distress or impairment of functioning. And again, is deviant. And so the main difference between this and other psychiatric disorders is that these disorders present with patterns of maladaptive behavior, while in other disorders, the behavior accompanies symptoms and signs. And so there's no symptoms that come along with the maladaptive behavior here. Whereas if we look at something like schizophrenia, we might see symptoms like hallucinations or delusions that could result in somebody behaving in a bizarre way. The reason they're behaving in a bizarre way is because of the hallucinations or delusions, not because of who they are. Whereas with these disorders, the individual is behaving in such a way because of who they are. There's no symptom in between those two things. All right, so we do have one general personality disorder, and this is usually if somebody does not fit any of the 12. Yep, 12 personality disorders, so technically there's 13. So, with a general personality disorder, this is what is going to be required to diagnose. Again, that pattern of inner experience and behavior that deviates from the expectation of your society. Again, so you have these personality characteristics that go outside of what is expected into society, and this pattern is manifested in two or the more following ways. So either with cognition, so ways of perceiving and interpreting the self, other people, or events. And we'll talk about this. So again, thought processes or affectivity. So this has to do with emotional responses. So how intense are people's responses? How non-present are people's emotions? So that all plays a role in affectivity. How well do they interact with other people? And then how well are they able to control their impulses? And so you need at least two of those. Okay. So B, the enduring pattern is inflexible and pervasive across a broad range of personal social situations. So again, the individual acts this way regardless of the situation. Regardless of the situation, this is how people act, the person acts. And it leads to clinically significant distress or impairment in social, occupational, or other areas of functioning. So maybe it's getting in the way of like relationships. Maybe it's getting in the way of work. Maybe it's somebody's getting arrested. Maybe they're experiencing a lot of emotional turmoil. And the pattern is stable and of long duration because this is their personality. This just isn't going to end like a hallucination or a period of depression. This is them. And its onset can be traced back to at least adolescence or early adulthood. If after that, it's not a personality disorder because personality is going to develop before that. And so you start to see some of these signs early on in life. And this pattern is not better explained as a manifestation or consequence of another mental disorder. So you need to rule out any other potential disorders that could be, whose symptoms could be causing this behavior. And it's not attributable to the physiological effects of a substance or any sort of head trauma. So you do need to rule out things like CTE, TBIs, any sort of brain injury. Okay, so with that being said, try to see here. Okay, so that's just going to be a general personality disorder. That's going to be the basis for most of these diagnostic criteria for the other personality disorders. They just start to get a little bit more specific in nature. Okay. All right, so these are going to be your clusters. Three clusters. So we'll start with A, work to B, work to C. I'll probably break this video up a little bit. But cluster A, these are going to be your oddness-centric personality disorders. And people with these disorders are going to have similar symptoms to those of people with schizophrenia, including inappropriate or flat affect. So they are reacting emotionally in ways that you would not expect, or they have a lack of emotional responsivity. They have odd thought and speech patterns, things like word salad, and may also be paranoid. They maintain their grasp on reality, though. And also, these are not things that come and go, like might happen with schizophrenia. Again, this is consistent across time and situations. So that's going to be cluster A. Cluster B is going to be the dramatic emotional personality disorders. These are the ones you've probably heard of more than any others. These individuals, people with these disorders, they tend to be manipulative, volatile, and uncaring in social relationships. They're going to be impulsive, sometimes violent, and show little regard for their own safety or their needs of others. And I didn't mention any of the cluster A, we'll get to them, but cluster B, some of the ones you might recognize are going to be like histrionic personality disorder, borderline personality disorder, narcissistic personality disorder, and antisocial personality disorder. And we will talk about antisocial personality disorder. It used to be considered to be psychopathology or psychopathy. Sorry, I'm getting ahead of myself. But psychopathy, that term really isn't used in this realm anymore. It's used it is commonly used in the realm of criminal justice, but we cannot diagnose somebody with psychopathy in the realm of psychology slash psychiatry. We can diagnose them with antisocial personality disorder, though. And if you look at like the psychopathy checklist, a lot of the symptoms of how somebody would conceptualize a psychopath are they do pretty much mirror that of the antisocial personality disorder. But again, we don't really use that term psychopath anymore in this context. Then we're going to have cluster C. These are going to be people with these disorders. They're concerned about being criticized or abandoned by others and have dysfunctional relationships with others. This could be obsessive compulsive personality disorder. And I think paranoid personality disorder, I'm probably mixing that one up, but I believe it's those two. And dependent, yeah, avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Going back to the top with cluster A, that's where your paranoid fits in, schizoid and schizotypal as well. So we'll go over them all. Okay, so all right, these are the three cluster A personality disorders, and I'll break them down a little bit more. But when it comes to these, they might show mild signs of schizophrenia, but they don't have schizophrenia. And this is where um, you'd have to rule out schizophrenia to make sure that it is not. But somebody with paranoid personality disorder, some of the features that are related to schizophrenia is that they don't trust other people. They're very suspicious. And again, they might act paranoid, which could be something that somebody might think is related to schizophrenia, because it's a little bit delusional, especially when they think others' motives are malevolent. And so its relationship to schizophrenia is pretty low, though, because that's all they have in common. Then we get to schizoid personality disorder. This one, we really don't know because we really don't have a great sample of individuals with schizoid personality disorder to study. But the part that is related or could be is that there's a detachment from social relationships and a restricted range of emotional expression that could be considered to be correlated to symptoms of schizophrenia. But again, we don't really know its relationship with schizophrenia. Schizotypal personality disorder, there's a relationship between this and schizophrenia. Um, and it's kind of considered a mild form of schizophrenia, but again, it's personality based. And because with schizotypal personality disorder, there's a pattern of discomfort when in close relationships. There are cognitive or perceptual distortions, so like delusions or like low-level delusions or hallucinations, and eccentricities of behavior, all of which are similar to those within schizophrenia. We will talk about that. So again, you won't necessarily hear people say, yeah, paranoid personality disorder is related to schizophrenia. There's a weak relationship. People might say, yeah, schizoid personality disorder, or somebody that's schizoid is schizophrenic. No, that's not true at all. It's not. And once we go over the aspects of it, you'll see like, no, that's not somebody who has schizophrenia. Schizotypal, yes, there is a correlation there. Doesn't mean they have schizophrenia, but it is correlated. So, okay. Again, here's another screen in regard to you have schizotypal, paranoid, and schizoid. And again, the negative symptoms of schizophrenia here. And again, so with schizotypal, this individual might have kind of a distorted reality, and these odd ideas, eccentricity, unusual experiences, superstitions, religiosity, suspiciousness, and then reclusiveness. Again, that could kind of be in there, as well as the negative symptoms. The negative symptoms of all of these are what are related to schizophrenia. And then you see the schizoid and delusional. So they all have um, their own criteria, but the ones they have in common are those negative symptoms that you might see in schizophrenia. Okay, so let's talk about paranoid personality disorder. Let's get this rolling. So, with somebody who has paranoid personality disorder, you're going to see somebody who is extensively distrusting and suspicious of others, such that their motives are interpreted as malicious or malevolent. And again, this is going to start in early adulthood and be present across contexts. It's not just like in their interpersonal or their intimate relationship. It's across context. So maybe it's at school, maybe it's at work, and it's in their relationship. So it's not just in one relationship. So you need four of these in order to be diagnosed. But again, you have to have this in general, but then you need to suspect without sufficient basis that others are exploiting, harming, or deceiving. One. And so again, you have to think that people are out to get you. The individual is preoccupied with unjustified doubts about the loyalty or trustworthiness of friends or associates. So they think that their friends are going to screw them over. Their partner is going to cheat on them. They're reluctant to confide in others because of unwarranted fear that the information will be used maliciously against him or her. So they don't trust. They're unwilling to share things. They're unwilling to divulge information to others. And again, this is across situations. This isn't just with one person, because in general, we probably all have that one person in our life where, we might feel this way toward. It's across situations with most people. They read hidden demeaning or threatening meanings into benign remarks or events. And again, that's kind of delusional. They bear grudges. They don't forgive. They're not going to forgive somebody from cutting them off in traffic. They perceive attacks on their character or reputation that are not apparent to others, and they're quick to react angrily or to counterattack. And so maybe if they are not invited to a small group lunch at work, they think that that's an attack on their character or how great of an employee they are, and they may seek vengeance. They're also they have recurrent suspicions regarding the fidelity of their spouse or sexual partner. So again, you need four of those. And again, this can't occur during a course of schizophrenia, like during a psychotic episode. It has to occur across time in different situations. So it can't happen during the course of schizophrenia, bipolar episode, depressive episode with psychotic features, or any other psychotic disorder. So you have to rule out all of those other disorders. And again, you're going to be able to tell because again, it's going to be across time, and we're talking about years, and in a lot of situations, most situations. Again, because that's their personality. This is their personality. It's not symptoms of a disorder. It is literally um, their personality. These these are these people are they're definitely going to be difficult to get along with. If we're talking about trade theory, these are people that would be very low in agreeableness, um, because they're going to have a hard time with close relationships. They're going to be argumentative. They're going to complain. They're going to be possibly be hostile. They might have, again, their emotions might run higher because again, they're suspicious. They're going to be hostile as well. Um, and so as a result of that, again, they're going to be difficult people to get along with and kind of turn themselves into outsiders because they're mistrustful of everybody. Also, they have to have, because again, they don't trust other people. They need to have a high level of control over other people. They're commonly critical of others. They don't work well on teams. And they have a hard time accepting any sort of criticism or anything but positive feedback for themselves. They're possibly going to blame others for their situation. Um, let's see here. The prevalence rate of this disorder uh, is around 2.5%. Um, let's see here. Across 6 epidemiological studies, 4 from the United States, they found a median prevalence of 3%. In the forensic setting, and so this would be like in a criminal justice setting, jail, prison, the estimated prevalence may be as high as 23%. So let me see what else I've got. Yes. in regard to these features, kind of like what I just talked about, yes, they feel like they're better than others, not to the extent that we're into narcissism, but they feel that they're better than others. They're going to scapegoat other people. They're going to be insecure. They're going to overestimate minor events and think that they mean something when they probably don't. They search intensively to confirm suspicions in others, so they're going to seek out what they believe is true. They're going to be high strung. These are people they're not going to have a sense of humor. They're definitely not going to be self-deprecating. They're envious and pathologically jealous, again, because they think that even their partner is cheating on them. They're critical they see of those they see as weaker, needy, or defective. They're going to have problems with authority because again, they're not going to trust them. They're going to question everything. They're going to argue. They don't work well in teams. The main emotional experiences of these individuals that are outside of the norm are anger and hostility. And again, they're going to be very independent and rely on themselves because they're paranoid of everybody around them. So, I think in regard to this disorder, there are in the development of this, yes, you're going to start to see it in childhood and adolescence, because you're going to see individuals that start to isolate themselves, have a hard time having friends, have some social anxiety, they don't do as well in school. They're super sensitive in friendships or relationships because they see everything as a slight. Um, the adolescent onset of this is usually associated with a history of childhood abuse, bullying, victimization. Um, and then there are some other environmental risk factors, uh, socioeconomic, socioeconomic inequality, if somebody's been marginalized, racism, that's all associated with having a decreased level of trust with society as well, and it's kind of adaptive. Um, so you might have those social factors, you may have childhood maltreatment, and then there is some evidence for an increased prevalence of this in relatives with, again, a very, very weak tie to schizophrenia, or even delusional disorder. So there may be a very, very weak tie with that. This is also more common in men than women. So hopefully that gives you a little bit of an overview of that. And again, yes, let me see your treatment. They receive typically receive treatment during a crisis, or again, because otherwise they're not going to go to a doctor, go to a therapist, go to a psychiatrist, because again, if you have a personality disorder, this is who you are, and you don't see a problem with the paranoia. This is egocentosis, but you don't see an issue. Again, if you have any of these personality disorders, you don't see a problem because this is who you are. So you are not going to end up in treatment unless there's some sort of a crisis, or you end up in the hospital, or you end up in jail. Or if you are dual diagnosed and you're also diagnosed with anxiety and depression, then they might be able to find this as well. So yes, and they're suspicious of everybody, so why would they seek out treatment? Also, when they are in therapy, therapist does not confront their paranoid beliefs, but increases social skills and skills for handling problems. So basically, being able to cope with the paranoia and manage their relationships and ability to function in society. That's really the way that therapy effectively approaches this. All right, so then we have schizoid personality disorder. And schizoid personality disorder, again, this we don't know if this is really tied to schizophrenia, but it's a pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings. Again, beginning by early adulthood and present in a variety of contexts, as indicated by four or more of the following. So let's just go through these, then we'll talk about it in more depth. But in general, these individuals, they don't seem to need interpersonal relationships. And as I've discussed across classes, humans are social creatures. And even if we don't necessarily like people or like social events or things like that, we need social interaction, evolutionarily speaking. So this is a really fascinating disorder. So again, four more of the following. So they don't desire or enjoy close relationships or even being part of a family in some cases. So they don't feel that need to have any sort of relationship with another human. They almost always choose solitary activities. Maybe it's computers or other hobbies in which they do not have to interact with other people. Maybe they are computer coders. They have little, if any, interest in having sexual experiences with another person because, in the first place, they don't necessarily want to have relationships with another person. So, sex isn't necessarily a part of anything for them. They take pleasure in few, if any, activities. Again, so that's part of the issue too, is they really don't have a large range of expression of emotions. And so they don't necessarily feel extraordinarily high rates of pleasure. They lack close friends or confidants other than first degree relatives, if they even have that. And they appear indifferent to praise or criticism of others. So they don't want to have interaction with others, and what others say about them really doesn't matter. Because again, that emotionality is very suppressed. They seem emotionally cold, detached, and again, they don't respond emotionally to situations that they should respond emotionally to. Also, this is not during the course of schizophrenia, any sort of bipolar episode or depressive disorder with psychotic features. Also, you have to rule out autism spectrum disorder because some of these characteristics could be seen in autism as well. And I know this is throwing a pop culture reference out there, but if you have ever seen Mr. Robot, I do not remember what streaming platform that was on, but Mr. Robot, the main character, he may be a very good representation of schizoid personality disorder. Okay. So again, they want to do things alone. So they isolate themselves. They don't want to be in social situations. They can't really relate to other people, and they don't really care to. Again, their range of emotions is very limited. They don't have a great sense of humor. They might seem to be distant and cold. But at the same time, they could be sensitive to feelings of rejection. That might be part of why they stay away from other humans. They may have deficient motivation. And just so we're clear here, these can all be mixed and matched. It's going to depend upon what type or where they are on the spectrum of severity of schizoid personality disorder. They may not have a lot of interest or hobbies because, again, they might not have high rates of pleasure. They don't necessarily want to pursue relationships. They prefer jobs that do not involve dealing with people. They sometimes work below their potentials. And on the other hand, they may show considerable creativity. So, again, this may, depending upon the criteria, some of this may be apparent, some of it may not. And again, we don't know the relationship between schizoid personality disorder and schizophrenia, so we can't make any assumptions that any of this has anything to do with schizophrenia. Trying to see if there's anything else here. They may have a hard time also expressing anger, even if they are provoked. That can also kind of indicate, make people think that they don't have emotions. Um, They may react passively to adverse circumstances. They may not be able to respond appropriately to important life events. Like if somebody were to die that is close to them, they may not be able to express the grief that other people would. Um, they date infrequently, often don't marry. Let's see here. So some theories of this. It may have increased prevalence in the relatives of individuals with schizophrenia or schizotypal personality disorder, but I'm gonna say may because we don't know. Um, we really don't know anything, if we're being honest, because it's really uncommon. It's extraordinarily uncommon. Um, the estimated prevalence, it's based on a probability subsample. So again, we don't really know because we do not have samples. And from the probability sample, it said it was about 5%. Another survey indicated about 3%, but a review of 6 epidemiological studies, again, this is the one where there was 4 done in the United States, prevalence rate of 1.3%. So somewhere between like 1 and 4.9%, but we really don't know because here's the other thing is that these individuals probably aren't going to get treatment. They don't enjoy having interaction with other people or developing relationships with other people. And in general, For the most part, they may be able to function okay in society. Yes, some of these things are going to get in the way of them functioning in a socially acceptable way, but in general, they may be able to function okay on their own. And they may not experience symptoms that can cause a ton of dysfunction or distress in their own lives. But if they were to end up in treatment, what a therapist might do is work to increase the awareness and expression of feelings. So, working on those emotions and improving social skills and encouraging interaction with other people. So, really just kind of looking at some of those deficits. Okay. All right. So, let's do schizotypal personality disorder. This is the last of the, and this is me being paranoid to make sure that we are still recording. So we have schizotypal personality disorder, and this one is or has a relationship with um schizophrenia. So schizotypal personality disorder. This is going to include you're going to have a pervasive pattern of social and interpersonal deficits, and you're going to have acute discomfort with and reduced capacity for close relationships, as well as cognitive perceptual distortions and eccentricities of behavior, usually beginning by early adulthood and present in a variety of contexts. As indicated, now we need five or more of the following. Okay, so these might be ideas of reference. And so like the ideas of reference, it's going to be like incorrect interpretations of casual incidents and external events as having a particular and unusual meaning. So it would be like if I was walking down the sidewalk and I stepped on just on like a manhole that like covers, some the sewer system in the ground. This would be like, oh, God put that manhole there just for me to step on. So you would start to see meanings in everything around you. And I know that's a very simplistic example, but you would start to see like everything that happens around you or that is present, it is there for some sort of reason or something is speaking to you. So you're getting into delusions. Also, again, we just need five. Odd beliefs or magical thinking that influences behavior or is inconsistent with like subcultural norms. Because again, some of these things, depending upon your spiritual beliefs or religious beliefs, may be considered to be normal in that subculture, so that doesn't count. But if it's outside that realm of normalcy, things like superstitiousness, belief in clairvoyance, telepathy, or sixth sense or seeing dead people, and children and adolescents, so bizarre fantasies or preoccupations. Um, so those would be included. Let's see here. Or preoccupied with paranormal phenomena. Again, it has to be outside of the subculture that one is a part of, because in some subcultures that those beliefs may be normal. So that wouldn't count. Uh, Unusual perceptual experiences, including bodily illusions. So um, something like sensing another person is present or hearing a voice murmuring their name. So almost kind of like a very, very low level hallucination. So you feel a presence there, kind of you think you heard something, or again, it's faint. It's not as vivid as maybe a hallucination with schizophrenia could get. Odd thinking and speech. So it could be loose, digressive, vague, but maybe not actual derailment or incoherence like you might see in schizophrenia. Suspiciousness or paranoid ideation. So they might think their coworkers are intent on undermining their reputation with the boss, so they're trying to throw them under the bus. Um, Inappropriate or constricted affect. Again, a lot of we're getting into schizophrenia realm. I do understand that. With the inappropriate or constricted affect. So again, they may not they may laugh at a funeral, or again, they may not be able to express the range of emotions that are necessary in a given situation. Their behavior or appearance is odd, eccentric, or peculiar. Sorry about that. They might wear bags on their feet, or they might wear their shirt backwards, or they might be wearing shorts outside when it is negative 30 degrees. Also, they may lack close friends and confidants other than their first degree relatives. They also could have excessive social anxiety that, again, it doesn't change with the familiarity of other people and is usually associated with paranoid fears rather than the negative judgments about themselves, which you would see in social anxiety disorder. But instead, it's because they're paranoid and mistrustful of other people. So, again, you're going to need five of those. Um, and it does not occur exclusively. Again, you have to make sure that this is not schizophrenia. A bipolar disorder or bipolar episode, depressive disorder with psychotic features, or autism spectrum disorder. So again, you are going to have to, because again, when it comes to schizophrenia, you are going to see episodes. You're going to see the positive and negative symptomatology, but you're going to see episodes. With an individual with this personality disorder, again, it's not as extreme as schizophrenia, and again, you're going to see it consistently across situations. Whereas with somebody with schizophrenia, you may not. Because again, with schizophrenia, they are symptoms. With schizotypal personality disorder, this is their personality across situations. So the prevalence rates of this disorder, again, with maybe 3% to, let's see here, 3.3 to 3.9 to that epidemiological study with three in the United States, they found a prevalence of 0.6. So anywhere from 0.6 to 3.9%. And again, this is going to be difficult, especially with personality disorders, because again, um, this is who they are. And in a lot of cases, people don't necessarily get treatment for their personality disorders unless there's some other disorder they may have that may be causing them distress, or they end up in like the criminal justice system or within like the healthcare system in some way, then maybe it could be identified. Okay, so again, here's some of the symptoms. They don't necessarily have close friends or confidants. They may be superstitious, bizarre behavior, suspicion, and social anxiety that doesn't improve with familiarity because, again, they're paranoid. Not because of their fear of being judged, like social anxiety disorder, but because they're paranoid of other people. All right, let's see if there's anything on here that I missed. I hope this also helps you, especially with your studying. So some theory that there is a biological basis. It does seem to be more prevalent among first degree biological relatives of those with schizophrenia than those in the general population. So that does seem to be a hint as to what causes this or is correlated with this. There may also be a modest increase in schizophrenia and other psychotic disorders in the relatives of those with this disorder. There have done twin studies that indicate there are genetic factors and some environmental factors that increase the risk for this disorder. As well, neuroimaging studies detect group level differences in the size and function of specific brain regions in individuals with schizotypal personality disorder in comparison with those with healthy persons. So you might even see altered brain structures in those with this disorder comparison to those without. Yes, so genetics, there could be problems with genes that regulate the NMDA receptor system. Cognitive difficulties in verbal fluency, inhibiting information and in memory. So those areas of the cerebral cortex, and also dysregulation of dopamine in the brain, which also occurs in schizophrenia. Also, you might see some environmental pieces like childhood adverse experiences, abuse, substance abuse, and also incarceration. Okay, so in regard to treating this, you could treat some of the aspects of this similarly as schizophrenia. So you might be able to use neuroleptics, antipsychotics, and antidepressants for some of the characteristics of it, especially like you're looking at some of those delusions, or characteristics of schizotypal personality disorder that resemble the positive symptoms of schizophrenia, you would be able to treat those with dopamine antagonistic drugs like your antipsychotics. Also, therapy. It's hard, again, like people with paranoid personality disorder, it's hard to treat these individuals because they have paranoia as well. But if you can help them test the validity of their suspicions by evaluating the environment. So basically reality testing, and then identifying and disregarding bizarre thoughts rather than believing them and acting on them. So again, a lot of reality testing uh, to work with this. Okay, so I'm going to stop the video right there, and then I will come back with cluster B personality disorders, and we will continue. I hope everybody's doing well. Thank you so much for sticking with me this far, and I will see you soon.